Good afternoon, ladies and gentlemen. Welcome to this session. This conversation is going to be about immunotherapy and targeted therapy and the future outlook in both these areas. And with me is Dr. Nitin Yashas Murthy. Welcome.
Thank you. Thank you so much for having me here. Really hope we can kickstart the post-lunch session with a good conversation.
Yes, I know. So let's begin. Tell me, doctor, have the cancer cases in India at the moment, have they gone down over the last couple of years? What have you noticed, or have they in fact increased?
So over the last 2-3 years, everyone has been obsessed with another word starting from C, which is COVID. For a decade, you possibly had cardiac diseases ruling the roost, but probably the emperor of all maladies, as we say, is cancer, and it's clearly increasing. So if you look at the Globocon 2020 data, the numbers are mind-boggling. You have 13 lakh new cases of cancer in 2020, and a recent ICMR report said that it is expected to grow by at least 12 to 15% every year as such. So, and I just heard in the previous discussion, one of the panel discussions saying that one factor is the population aging as such, another is increasing dynamics, but always we would like to highlight again and emphasize that cancer is more of a lifestyle disease. And beyond the numbers of looking as to whether cancer is actually increasing in the country, what is slightly worrying for the Indian population is that we are beginning to see it come at a younger age, which again probably correlates with the fact that it is becoming a lifestyle disease or multifactorial in etiology as such. And that's not it. Again, the worrying factor for us oncologists is always, when you look at the ICMR report and what we see in clinic as well, less than 30% are detected in early stage. A majority are detected when it has spread to the lymph nodes already, which is stage 2, stage 3. And if you look at lung cancer as such, 50% present in stage 4. And that's the worrying trend of cancer, and that is why we appreciate BW World and all the NGOs and all the other institutes, that really you have to stare it in the face, talk about it, and spread awareness of it to reduce the stigma for early detection.
Right. So, basis what you just said, so that means being aware and screening. These are the key factors.
Absolutely. Now, sometimes I do get patients, unfortunately, who come and said they have just undergone a whole body checkup, but still the cancer has come. What we also need to sort of cut down the hyperbole across the media and across the medical fraternity too as well, is that there are only some cancers which can be screened and detected early. And fortunately, it's the most common cancers. Breast, cervix, colon cancer, lung cancer in smokers. These cancers which are the most common can be screened and detected early. Prostate cancer to an extent. So it's not all cancers that can be screened and detected early, but definitely the most common cancers can be screened and detected early as such.
So cancer research has progressed quite a bit. What support can the government give towards, cancer research?
So, when we talk of cancer research, possibly in the medical fraternity, most think about clinical trials. When you look at a new drug coming in and you say that, let me check whether it's working against the standard of care. But I think cancer research in the country has to evolve beyond that. I think I would like to categorize it into sort of, let's say, 3 aspects. One, the medical education needs to undergo a radical change where research becomes one of the primary focus. And recently, the Indian Institute of Science in Bangalore is thinking of launching a dual MD PhD program. So that is going to incorporate mainstream basic science research into clinical training as well. So that's very important. And the second is always, we have a lot of data coming in from the West. And in fact, some of the discoverers of chemotherapy drugs are Indians, like Mansukh Wani, who discovered it, but it was discovered in the US as such. The fact is always, we have enough of bright minds as we have seen in other spheres. But tell me, how many of medical innovations do you see coming out of India, barring from the tech space in the basic science research? And that's where funding needs to improve from the government side. And more importantly, ecosystem, which is by and large the key word these days, creating an ecosystem of collaboration between basic science institutes and cancer institutes. Like, for example, IIT Bombay and Tata Memorial are collaborating in building CAR T cell. So we need to see more of those as such. And really, again, cancer is a stigma, like I said, and even people among the medical fraternity or medical students do not know how much advanced cancer has become. Yeah. And unless you sort of light the stimulus in them, that's the only way research is going to move forward.
Right. And this is also very important because like when we were chatting earlier, where you said that, not many people who are not medicos, basically, non-medicos, they do not know that there are various types of cancer that can actually be cured.
Exactly.
And when you said that, I was a bit taken aback.
So I'm pretty sure everyone in the room or anywhere outside, when you would have gone yourself or taken one of your family members, you would not have asked the doctor, "Doctor, can I be cured of diabetes? Doctor, can I be cured of hypertension?" No, that's not a question anyone would ever ask. People live with it. But the reality is stage 1 to stage 3 cancers can be cured. You talk of stage 1 breast cancer, you have a cure rate of 90%. You talk of stage 3 breast cancer, yes, it comes down to 70%. But cure is a word that we use after 3-4 years after the cancer does not come back as such. But the reality is earlier detection translates to cure. And now we are talking of incorporating maintenance strategies to reduce the risk of relapse.
Right. So let's talk a little bit about immunotherapy. So for some of the people in the audience, if you'd just like to explain what immunotherapy is, why is it considered more effective, or in fact, if that is the case, and in terms of stage 4 cancer, is it effective? Is it the most effective therapy?
So basically, immunotherapy has changed the entire landscape of cancer, and I was fortunate that at Manipal Hospital, Old Airport Road, under the leadership of Dr. Amit and Dr. Poonam, I could get trained in immunotherapy when it started picking up. So immunotherapy is a remarkable concept. It won the Nobel Prize in 2018. So immunotherapy are nothing but IV medicines which activate the body's immune system to go fight the cancer cells. Now, essentially, why does cancer happen? Now, cancer happens because there are mutations, which are changes in the DNA happening constantly. And when there are cells which have mutations, usually the immune system takes care of it and eliminates it. But when the cancer cells become clever, they express certain proteins which prevent the immune system from recognizing it. And that is what immunotherapy does. It eliminates that mask or facade, so to speak, so that the immune cells can go and attack cancer as such. And really, in stage 4 cancers, we used to talk of survival in terms of weeks to months, but now we are talking in terms of years with a potentially cured patients. Now, always in stage 4, we don't use the word cure as such, but we always say we are seeing stage 4 cancers who are surviving after treatment with immunotherapy for years.
And so, when we talk about the differences between immunotherapy and targeted therapy, could you explain some of that?
So immunotherapy is essentially a type of targeted therapy as such. So targeted therapy is essentially personalized medicine. That is, you are not, so if anyone gets fever, you give dolocrocin, whatever, to everyone. Cancer treatment has advanced beyond that. We even say that breast cancer is not one disease anymore. You look at, are the hormone receptors positive? You look at, is it HER2 expressing, or is it triple negative as such? So targeted therapy is essentially you take the cancer tissue or the tumor and you do next generation sequencing to see what proteins and what genes are expressed, because now you have targeted therapy to treat it as such. I don't know if,
Can we have the slides, please?
Yeah, so this were just some stories that I would like to share as such, that on the left you see the PET scan, on my right you see a PET scan. This is a 55-year-old lady who came with stage 4 kidney cancer, which had spread to the liver, the bones, and the mediastinal lymph nodes. We gave immunotherapy. 2 months, this is the PET scan which you see. Complete disappearance. And this is not just one patient. In fact, we published our study where out of 35 patients in stage 4 kidney cancer, 5 to 6 of them went into complete response with survival stretching beyond 3 years. And they're not on treatment. We stopped treatment after 1 year, which again gives credence to the fact that once the body system, immune system is activated, it can take care of the malignancy and keep the malignancy under control. She just came 2 months back, happily carrying out all activities. But like you said about targeted therapy, next slide, the one place where targeted therapy is really making inroads is in lung cancer. So the biggest question people ask is, why does lung cancer happen in non-smokers? And the answer is there are mutations which happen. So this was a 70-year-old gentleman, very elderly gentleman, who came with seizures, fits, unable to speak. When we did an MRI of his brain, the cancer had spread to the brain. Across all the white, fluffy things which you see on the MRI image, that's the cancer which has spread. Now, when we did the mutation analysis of his genome, it had an ALK mutation, which is present in about 5% of cases. So imagine we have reached a time when a stage 4 lung cancer which has spread to the brain, we are treating with oral tablets and not chemotherapy. 1 month in the hospital, we discharged him. 3 months later, the daughters came into the OPD. And when our patient relatives come without the patient, you're a little worried. But they came and showed this MRI. Complete disappearance of the tumor just after 3 months. And today, the 70-year-old gentleman is 75, playing with his granddaughter, walking in the park, and trying to become a social media influencer by vlogging his journey. And that's the impact of targeted therapy, where this is what we talk of targeted therapy, that you sequence the tumor to understand what genes are there. Now, again, I don't want to sound too much of hyperbole, but the reality is, in non-smokers in lung, 30% of them have a EGFR mutation. The rest, 10-15%, are of varied other mutations. And even in other tumors, if you do the gene sequencing as such, and you find a mutation, sometimes you don't have the medicine to target it. But the fact is, science is advancing. You're now talking more and more about oral tablets and targeted therapy, and looking at gene sequencing to identify what weapons are the cancer cells expressing. Weapons, proteins, pathways. And let's kill and direct our therapy through those pathways rather than using chemotherapy, which just blindly kills all cells. Chemotherapy is still the backbone, but you're now beginning to refine treatment by adding more and more precision medicine that we call.
So when you choose immunotherapy, is it that it is chosen just by itself, or do you kind of...
Yes, so it depends on which cancers immunotherapy works the best.
And what stage it is at. And
Absolutely. So most of immunotherapy approval right now is in stage 4 cancers.
Yeah.
Skin cancers, kidney cancer, lung cancers.
Yeah.
And now you start looking at markers. So is the body's tumor actually in an immune suppressed environment? So you look at the protein called as PD-L1. If PD-L1 is high, sometimes you can use only immunotherapy. If PD-L1 is low in certain cancers like lung cancer and stomach cancer, you can combine immunotherapy with chemotherapy to achieve that synergism. 6 months back, there was a big media news of a drug miraculously curing rectal cancers as such. That was immunotherapy. But what sort of didn't go was that it was a trial which was done in only 12 patients, where they were going to be responsive to immunotherapy. Those patients had a biomarker known as mismatch repair protein. So like I said before, all of us have cells which are undergoing mutation, but the body has a repair system. Now when the body's repair system is distorted, particularly this repair system known as MMR or mismatch repair, these patients respond very well to immunotherapy. We have a stage 4, my professor has a stage 4 stomach cancer who is this mismatch repair protein deficient on immunotherapy for 6 years now. In a stage 4 setting, and that's something we would never ever imagine. 40-year-old with stage 4 esophagus spread to the brain, we started immunotherapy and it's now 4 years. So you always say again, immunotherapy works, I want to be clear here that immunotherapy works only in about 20 to 40% of patients. It doesn't work in everyone. But where we are moving forward is that we are seeing that in these 20 to 40% of patients, survival is stretching in years in stage 4. Similar to what you're seeing in chronic kidney disease or other chronic diseases as such. And now immunotherapy research is ongoing and some approvals have come in where you're starting to use them even in early stages, either as maintenance or before surgery to shrink the tumor dramatically.
Right. So tell me about how much progress has been made in the field of immunotherapy over the last...
Lots. Like I said, when I started my residency, sometimes we were using immunotherapy very blindly.
Yeah.
Now we sort of know which markers to use. Do we combine it with chemotherapy? Do we combine it with some sort of targeted therapy? And we are also getting to the stage, because immunotherapy are expensive medicines at this point of time, we are getting to a stage where we are saying if someone responds very well, can we stop treatment earlier? And that's the data which we presented recently at an international conference, that incomplete responders, like I said, you can get away by just a limited duration of treatment rather than lifelong treatment, which used to be thought before, and patients are doing well once the immune system is activated.
So what is the future outlook, according to you?
So the future outlook is that everyone has to be aware that cancer should not be something people are scared of. Usually when the word cancer is mentioned, the words which come are hopelessness, terminal disease, something which cannot be cured. I think now we are moving to a space we are going to be talking of hope and courage, not just in terms of mental positivity, but sheer scientific evidence backing that we are understanding the disease better, and that immunotherapy, targeted therapy, and particularly precision medicine, it's not one size fits all. It's understanding that, yes, we need to sequence a patient's tumor, understand, we in cancer, oncologists always use one term, we say biology is the king, which is to say how the cancer behaves, what are the proteins it is expressing, where has it spread is going to dictate treatment as such. So for example, if a patient comes with a 4 centimeter breast lump and the patient is expressing a protein known as HER2, we don't operate anymore upfront. We give chemo plus targeted therapy, and sometimes we add 2 targeted therapy, and we are able to make the complete cancer disappear in about 50 to 60% of patients. But that doesn't eliminate the need for surgery. It just shows that the disease is responsive to treatment and the chance of cure is going to be high.
So you're saying that the chance of it coming back is lesser?
Is lesser. So is in the same situation, let's say that tumor did not reduce completely to the treatment we give. Now we have moved to an understanding that post-surgery, we continue on another form of injections, a second generation of injection for 1 year to reduce the risk of the disease coming back as such. So we always say, the earlier you start, the lesser the chance of it to come back. Cancer is not just a localized disease, it's a systemic disease, meaning to say, there are always some cancer cells which are floating in the blood, which is why doing only surgery in all cases or doing only radiation plus surgery is not going to be important. You need to control the disease which has spread to the blood and may be floating around to reduce the chance of it from coming back.
Is this true even for like a stage 4 cancer?
So in stage 4 cancer, you always do not talk, in stage 4 cancer, your mic,
sorry.
In stage 4 cancer, you always do not talk of cure. You talk of bringing the disease down and keeping it under control. But like I said in the 2 examples which I cited, you're talking of people who are potentially living without any disease for long term. Right? Cure is a word which we still refuse to use scientifically in stage 4. But like I said, it's like diabetes and hypertension now. Patient has responded, kept the disease under control, carrying out all his activities. Some of them have even gone to serve in the border as part of our armed forces. Some of them have gone back to play sports. That's the progress oncology has done. So again, it comes back to the stigma. When someone is taking a cancer tablet, they always ask, when should we stop? But it doesn't happen with the sugar and BP tablets. So that's what I'm trying to emphasize. We need to change radically the way we think about the disease, because if you're already going to think we are beaten by the disease, then there's no hope.
That is true. I wanted to know, are there any side effects to...
So immunotherapy does not have the traditional side effects of chemotherapy, because immunotherapy is sort of activating the body's immune system. You tend to see some immune-mediated side effects as such. So we have given immunotherapy even to an 87-year-old with stage 4 CA lung who went on to live for 3-4 years. And the most common side effect of immunotherapy, which we have seen in our study of close to 250 patients, is thyroid function disturbance. Very rarely the immune system can get so activated, it can cause arthritis, it can cause severe diarrhea because of inflammation of the intestines or pneumonitis as such. But by and large, the most common side effects we see are fluctuation of the thyroid levels and some skin rash. But very, very well tolerated, which is why we use it even in the elderly as such, that it does not have the traditional side effects of chemo.
That's wonderful. So now, since we are running out of time, I'll quickly ask you about, remember we were speaking about policies earlier. Could you tell us a little bit about what, in your opinion, should be the policies that can help advance cancer care?
Right, I'm very fortunate and privileged that I get to address this topic in front of leaders and business world as such. is that you have the science available now. You're making a lot of progress in the field of oncology, but you're not making progress on the policy direction. Now, the oral tablets, which I told you, some of the second generation, third generation cost above £1 a month sometimes. Sometimes it may cost 50 to 70,000. Now, if they have the insurance premium and coverage for it, why should it be denied? You still have insurance companies denying oral cancer tablets, saying, because you're not being admitted, we will not cover it for you. Sometimes even immunotherapy is not covered as such. And that is where a radical policy shift needs to come, because when you're giving a DCGI approved therapy, when you're giving something which is not experimental, and the patient has insurance coverage, why should it be denied just because he's not being admitted? Absolutely. And that is where you're making progress in the field of science, where you don't want patients to be admitted, but you're ending up with roadblocks in the insurance sector or policy sector as such. And the second most important thing from a policy aspect, again, is to provide incentives to institutes, pharma companies, healthcare industries to prioritize screening and early detection. Yeah. We need to think of some incentive factor there where companies, even corporates, for the regular wellness check of their employees, need to be incentivized that you have to do a certain number of cancer screening programs for your employees. Because again, like I said, the most common cancers are detectable early. Some of them are preventable, like cervix cancer and even colon cancer, because you can pick up precancerous lesions and remove it. Yeah. So we need to start looking, because as the age-old adage goes, prevention is better than cure.
Right. Thank you so much. Ladies and gentlemen, we've run out of time, but if there's a question, yes.
No, so again, CAR T cell is a type of immunotherapy where essentially the patient's cells, white blood cells, are being removed, and they are being modified outside the patient's body to go and attack the cancer cells, and they are being reinfused. It's predominantly working more in blood cancers or the space of hematology as such. Some of the Indian cancer institutes are trying to bring in Indian version of CAR Ts as such. Tata Memorial has tied up with IIT Bombay. So FDA has approved it. CAR T has been proven, and that's again a policy point, that the FDA approvals which come, the DCGI, always there's a lag. Yeah. So it may be approved in the US, but in India, it takes more time to approve. For what reason, we don't know, but these are things which can be looked at. But yes, CAR T cell is an approved therapy for treatment, especially in certain blood cancers which relapse.
What is the best option for multiple myeloma?
So multiple myeloma, as of now, we say at the first line setting is a bone marrow transplant. There are studies which say at relapse you can do transplant. Now, despite transplant, if there is a relapse as such, we say CAR T is also coming in. But multiple myeloma, there are a lot of newer therapies also available, including a specific targeted therapy which goes known as daratumumab. So multiple options in multiple myeloma.
This one is tried? What you said?
Daratumumab, yes, it has been in for the last 2-3 years. We are using it in a certain group of patients. Approved, yes, absolutely.
What is the cost for this?
Cost is, it again depends on the body weight, the dosing as such. It would be upwards of £1 a month as such.
And for how much time?
So again, it depends on what setting it again depends on what setting you're using. Are you using it as a bridge to transplant, or are you using it in a refractory setting?
I'm so sorry, I'm being told. Just one last question, and then.
Yeah, so I don't have any personal experience with natural killer cell therapy. I do have certain patients who have come, correct. So I do have certain patients who have gone to either Japan or in certain parts of North India where dendritic cell therapy or natural killer cell therapy is done. But we still don't have sufficient good quality randomized controlled trials which have compared it to standard of care. But once that is done, you possibly would see it integrate. And very quickly summing up on challenges of immunotherapy, it comes down to cost and accessibility. As compared to targeted therapy, which you still sometimes have certain generics available for certain targeted therapy, you don't have any generics available for immunotherapy as such. So the major issue always turns out to be cost and accessibility.
Thank you so much.
Thank you so much for this wonderful opportunity.